Okay, so well, I guess we heard about EGFR mutation for a long time. There are many types of mutations, and the more tests we do, the more mutations we find. And in fact, there are now companies targeting rare mutations as a strategy. Grossly, we have sensitizing mutations, and the most common ones are in exon 19 and 21. And then we have EGFR resistant mutations. T790M is clearly the most frequent one, but there are others. They are concentrated mainly in exon 20. So in general, exon 20 mutations are resistant mutations. I'm talking here about resistance to first generation inhibitors. That's where we have the most data. And it's already now, 10 years ago that we know about the T790M mutation. And actually, if you look at the original publication, there is a drug out there that has a number, here, CL and then a long number. That's actually an irreversible EGFR inhibitor that has never really made it to the clinic. But it is actually active on the T790M mutation. And that was really very important to see because that really started the whole development of second generation and then third generation inhibitors. So Suraj already showed you a summary of my slide. But I actually went through all the literature for the last 10 years, and this is still a limited number of potential mechanisms of acquired resistance to third generation TKIs. So clearly T790M is 50-60% the most common mechanism of mutation, but there are other resistant mutations that have been described in exon 20, less common than the T790M. Activation of parallel pathways is also very important, and this is difficult to target sometimes. It could be MET amplification, overexpression of the ligand, HER2 amplification, IGF-1R amplification, and many other kinases that can be activated as a resistant mechanism. And apparently, these could be a dynamic process. So you could have an activation of a pathway, and then you try to inhibit that one, and then the tumor will switch to another one. Mutations in BRAF, in PI3 kinase, PTEN loss, and F1 loss. And then a small cell lung cancer transformation, which is probably rare. I think everybody has seen one. And the literature is quite different. You have reports of very low frequencies, 3% up to 14%. And then there are overlapping mechanism of resistance, and I think that this is an underestimate of 4%. I think they're probably more than that. It's just that we cannot look at all of them in the same sample. And lately we have had also a report in lung cancer of RET rearrangements in a couple of patients, which is also targetable. Now this is a slide from Lycia's recent review in Cancer Journal. And this represents, I think, a summary of the literature. So again, you can see the T790M mutation with several different flavors in combination with EGFR amplification, for instance, or EGFR point mutations, resistant mutations. So again, you start seeing overlapping, potential overlapping mechanism of resistance. And then on the left side, you have bypass tracks up to 20%. And again, here she includes also small cell lung cancer. And this is a report from Memorial Sloan Kettering. So doing this on systematically on 155 patients on which serial biopsies were performed. And again, 60% T790M, and then some other, probably less complicated mechanism, because this was a relatively limited effort compared to the literature, of course. An interesting report here from a couple of years ago is that the patients that have a T790 mutations have a better prognosis than those that don't have a T790M as a mechanism of resistance. Now, I'll talk a little about the small cell lung cancer transformation because I think it's important, maybe not so much because the frequency is low. I mean, not so much for its frequency, but because it really opens questions about the etiology of the small cell lung cancer cells and non-small cell lung cancer cells, and how can you treat these patients most efficiently. Right now, when you have a transformation into small cell, people tend to give chemotherapy, a chemotherapy that is platinum-based, like in small cell lung cancer, and patients respond. So what happens here is that the cells are clearly resistant on this graph here, and this is a control with a T790 mutation. And here you have a loss of EGFR expression in these cells. And this is what you see also in small cell lung cancer cells, very low level of expression of EGFR. And again, here, these are tissues. This is the small cell lung cancer transformation, and this is a non-small cell lung cancer with T790M. And looking at all the data points, there's a clearly very significant difference in terms of EGFR expression between pre-biopsy, pre-treatment biopsy, post-treatment, and post-non-small cell lung cancer overall. So that's one thing that is known. The other thing that is known is that in these tumors, there is also a genetic loss of the retinoblastoma 1 gene, as you can see here. This is quite common in small cell lung cancer, much less common in non-small cell lung cancer. But this seems to be important but not sufficient for the transformation. They have done a number of genetic tests and proved that this is essentially not significant, not sufficient. So what we know is that it's between 5 and 15% of EGFR acquired resistance. These tumors retain the original EGFR mutation, and this is a dynamic change. So patients that have been treated with chemo for the small cell lung cancer transformation, they may go back to become a non-small cell lung cancer and maybe acquire some other mechanism of resistance later on. There's a loss of EGFR expression, a reduced EGFR amplification, and genetic loss of retinoblastoma 1 gene. And interestingly, looking at the literature, there's also now a case report of a transformation into a large cell neuroendocrine carcinoma as a mechanism of resistance. And this is a report from Japan. So maybe the morphology is not essential in this case. And this is again from Mitsudomi's group. He reported an autopsy study on a patient who developed EGFR resistance to first-generation inhibitors. And they picked up 9 lesions. And what they have demonstrated is that in 2 of the lesions, there was the original deletion 19 and the T790 mutation in an adenocarcinoma morphology. 6 lesions had a deletion 19 and a small cell lung cancer morphology, and 1 had both. So essentially indicating that probably mechanism of resistance, and we knew this already, are different in different sites. And small cell lung cancer might be one of the mechanisms in some of the sites that we have. Practically, I don't know how to address this. I don't think we can do 9 biopsies in a patient who progresses. So maybe the way forward could be, in fact, looking at liquid biopsies, biopsies. So this is what was mentioned before, using circulating tumor DNA as a potential way of getting around the necessity of having tissue. The study presented by Licia with ruxolitinib at ASCO. And as you can see here, the major endpoint response rate in this case is identical, whether you take the tissue T790M or the results of the circulating tumor DNA. Now we know that probably these numbers should go lower, but maybe they're still comparable. And from this paper that she published in Cancer Discovery a couple of months ago, essentially there were several mechanisms reported there. These are only 13 samples, and there she reported small cell lung cancer without a T790 mutation, and non-small cell lung cancer without T790 mutation, a T790 mutation positive non-small cell, and T790 positive non-small cell with an amplification of EGFR. Again, complex mechanism of resistance. And by following serial liquid biopsies, you can actually see what happens to the several components. So the T790M, the wild type EGFR, and in several patients, things can go, in fact, different directions. And this is the last thing that she mentioned. Essentially, there's no single dominant mechanism of acquired resistance to ruxolitinib that we've been able to discover so far. Granted, it's only 20 cases now that she presented at ASCO, so we probably need more data. And this is the other drug that has just been approved, the AstraZeneca compound, osimertinib. And here we have plasma for 15 subjects with acquired resistance to the drug. And again, this is from Oxnard. He used cell-free plasma DNA analysis using droplet digital PCR. And there were 3 patterns in this study. One was the T790 mutation plus the C797S mutation in 6 cases, T790M alone in 5, and absence of T790M in 4. And what is interesting is also to know that the C797S parallels the C481S Bruton tyrosine kinase mutation, which occurs when patients become resistant to ibrutinib. So essentially a parallel, again, like we saw for the T790M in CML parallel. So if you have this novel mutation, C797, essentially cells are completely resistant to AZD9291, that you can see here, both in presence of the deletion 19 cells and the L858R mutation. And this is true for both the AstraZeneca compound and also for the Clovis compound. And again, you can see here that essentially in presence of this mutation, you are unable to downregulate phospho-EGFR. And again, using plasma DNA, you are able to follow now these clones. And some of these clones will come back, and then you know that there's resistance coming up again. So, and this is a very recent report from a group in Korea, 4 cases also treated with the AstraZeneca compound. So they had partial response, all had a deletion 19 mutation and T79 mutation to be able to enter the study. And what they have seen here is that in 3 out of the 4 cases, there were a depopulation of the T790M, similar to what Suresh mentioned before. Essentially, because you treat the T790M specifically, at least you put the level of this mutation to a very low level, less than 1% versus 14 to 36% at baseline. One of these patients also had an FGFR mutation, and another patient had a small cell lung cancer transformation, again indicating that there are potentially multiple overlapping mechanisms of resistance. And one case had a P10 deletion. And this is a report from Memorial Sloan Kettering, and this is, I think, interesting to see because it shows how things develop, and we are talking about years in this case. So 2009 diagnosis, and there was just an EGFR mutation, sensitizing mutation, and then appearance of the T790M treated with the AstraZeneca compound, and then appearance of the other third mutation in this case. And of course, there may be another little thing here showing another mutation probably. So this is a major issue. And one thing that Pasiani showed in this paper is that when you treat with both a 3rd generation inhibitor, this WZ compound or gefitinib, you have a very quick reactivation of ERK. As you can see here, already after a couple of days, you have ERK phosphorylation coming back. So these are reversible inhibitor, at least this one, but this is irreversible. And this happens after already a couple of days. So what he has done is trying to devise methods of preventing this and then treating patients who have this genetic makeup. And what he has done is a combination of these 3rd generation inhibitors, WZ, with trametinib. And what he shows here essentially that you can then wipe out phospho-ERK for a much more prolonged time in the cells that receive the combination. Let's see. So, and then he went out demonstrating that the combination is effective in both TKI naive cells, in T790 positive cells, but is not active on the non-T790M mutation type of resistance. So essentially indicated that this is a quite specific type of action that you can get when EGFR alterations is the major mechanism of resistance. And in patients that have already tumor formed, when you give this combination, you can actually obtain cure in a number of mice that were treated in this case. And so that was it. I'm not really sure if this combination is going forward in the clinic, but it's certainly a very interesting approach. As Suresh mentioned before, Jeff Engelman has pioneered ways of developing new strategies or how to treat patients with TKIs, EGFR TKIs in particular in this case. This is a paper that came out about a year ago using primary cells to develop ideas of what the mechanism of resistance would be, and then primary cells that would be exposed to a chemical library of a lot of compounds. And so by doing this, they were able actually to identify what the mechanism of resistance was, and at the same time also a drug that could target that. So this is an example showing that MET inhibitors came up as a potential targeted drug for this case, and then they did this in vitro in the primary cells, and they were able to show that this was actually working. Now, I spent the last couple of minutes talking about something totally different. We always talk about acquired resistance, and we know that everybody is going to have it. So it's a very important mechanism, and we keep talking about acquired resistance to second generation, third generation, we will have a fourth generation. And there's very little done in terms of looking at intrinsic resistance, and I think that there is value in studying this. We know that a good 20 to 40% of the patients do not really respond to these drugs. They have either immediate progression or a very short stabilization. Not well studied. We know that KRAS mutations is mutually exclusive with EGFR mutation, so by itself, it excludes patients from this type of treatment. And resistant mutations like T790M have been described, but they are very rare before treatment with an EGFR TKI. We don't really know if there's an activation of parallel pathways, and from Asia mainly there have been indications that BIM deletion polymorphism might be responsible for intrinsic resistance, but they were not confirmed in other reports. So we looked at crypto1 because crypto1 is involved with the stemness of tumors and has been related to resistance to a number of drugs, chemotherapeutic drugs and others. And it is also involved in epithelial to mesenchymal transition, which is an important mechanism of drug resistance to a lot of drugs. So essentially, we engineer cells that have an overexpression of crypto, and we showed in vitro and in vivo that if you have these, there is actually a very high degree of intrinsic resistance to first generation and second generation dacomitinib inhibitors. We show this both in vitro and in vivo. What we also showed that this doesn't work for normal chemotherapeutic like Taxol and cisplatin. And when you look at the pathway that is involved in this, you can see that there's a strong SRC activation, and there is activation also of the epithelial to mesenchymal transition, and also increasing invasion and the migration in these cells. And because SRC is activated, then we use SRC inhibitors and SRC shRNA to block this pathway. And when you combine them, both in vitro and in vivo, you can have strong synergy in determining potentially an effect of combining then a SRC inhibitor with an EGFR inhibitor as a preventive measure for intrinsic resistance to these agents. We looked, of course, this is all in vitro and in vivo, so the reviewers also asked us to take a look at the samples, and here you can see just by immunohistochemistry that responders have a lower level of expression of crypto-1 than patients that have intrinsic resistance to these drugs. Now we looked also at third generation EGFR inhibitors, and the same thing seems to happen also with the AstraZeneca and the Clovis compounds. There's a very high level of resistance in presence of overexpression of crypto-1. So I think there is value, in fact, in looking at this much more carefully, considering again that up to 40% of the patients don't really respond to the third generation inhibitors. So in conclusions, acquired resistance to EGFR TKIs, there are multiple mechanisms known. Most of them are known for first generation inhibitors, much less is known to third generation inhibitors. Some of these alterations are targetable with novel agents, but this is a dynamic environment and things change back and forth. And prevention resistance should really be investigated as well as, and this is probably related to intrinsic mechanism of resistance, because this could have a bearing also for acquired resistance. Thank you for your attention.
We have time for one question.
Oh, thank you. The small cell transformation is, or I don't know if I want to say, you've had a couple of cases, and I've heard it's where they actually found small cell as the mesoresistant. Is that like in a CLL, a Richter's transformation? Is it really the same cell that generates or changes into small cell, or was it a mixed tumor with a very small cell component that finally is unmasked? Do we know?
Yeah, well, so they maintain the same EGFR mutation, so it looks like it's the same cell that really transforms, changes morphology.